Good afternoon. Welcome to the HIV Health Improvement Affinity Group, State Medicaid Programs, and In-Depth Look. My name is Michelle Brown. I am with the Centers for Medicare and Medicaid Services, and today I'll be your moderator. Before we move forward, I'm going to give you some brief logistics for our call today. If you are unable to listen to the webinar through your computer speakers, please use your phone. The dial-in number is 844-404-0018. The access number is 584-04329. During the webinar, lines will not be open. Comments are encouraged. Please use the chat box on the lower left corner of your screen. The chat feature is available but will not be visible in the full screen mode. The purpose of our webinar today is as follows. While Medicaid programs varies greatly across states, the goal of this webinar will be to help attendees better understand the overarching structure and components of this program, as well as spur discussions among state teams about areas for collaboration between the Health Department HIV programs, other round-wide HIV programs, and Medicaid agencies. Please allow me to do a quick roll call of our Infinity Group team participating today. When I call your state, please use the chat box on the lower left corner of the screen to let us know that you're here today. I'm about to begin the roll call. California, Georgia, Iowa, Maryland, North Carolina, Wisconsin, Illinois, Louisiana, Massachusetts, New York, Rhode Island, Washington State, Alaska, Connecticut, Nevada, Michigan, Mississippi, New Hampshire, and Virginia. Thank you very much. I'm seeing we have many states represented today. Now, it is with great pleasure that I introduce our speaker today. Our speaker is Ms. Kathy Dunn. Ms. Dunn is currently a Senior Program Director with the National Academy for State Health Policy. Prior to joining the National Academy, Ms. Dunn served as the New Hampshire Department of Health and Human Services for 23 years, beginning as the Bureau Chief of Communicable Diseases, and then as a nurse consultant in maternal and child health. She was promoted and served as the Director of Public Health and Medicaid for the state of New Hampshire from 1999 to 2003, the Deputy Medicaid Director from 2000 to 2003 to 2008, and in 2008, she was appointed to be the Associate Commissioner and State Medicaid Director. As the Medicaid Director, Ms. Dunn has overseen a number of health systems and Medicaid reform initiatives, including most recently the transition to Medicaid managed care and a premium assistance program as part of the state's Medicaid expansion initiative. In addition to being a registered nurse, Ms. Dunn received her master's degree in public health from Boston University with a concentration in health services administration. Without further ado, Ms. Dunn, please begin the webinar.
Thank you for the kind introduction, and welcome everyone to our webinar today. Before we begin going through the slides, I do want to acknowledge and thank our federal partners who've been working with us on this very important project, including the CMS, the Centers for Medicare and Medicaid Services, the CDC, and of course HRSA. Without everybody coming together, this would not be possible. So let's move on to our first slide. What I have set for session objectives today is at a very high level to describe eligibility, benefits, and administration of the Medicaid program, and also of the Children's Health Insurance Program. And I remember in my many days in my time in New Hampshire, somebody would say, oh, it's Medicaid, you know, they've got to be able to stop and turn on a dime. They can make changes really easily. You can get around federal regulations, and I'm here to tell you that no, that is not correct. And it is important for non-Medicaid programs, and I found this as having public health programs such as the HIV program, such as maternal child health, et cetera, within my office. There's great ways to leverage the work in the Medicaid program to have it come together, but it all has to be done within the context of your Medicaid director and program staff trying to stay on the right side of all the federal and state regulations. Next slide, please, Kara. So what we're going to touch upon is what is Medicaid, and then the topics that you see on the slide. I'm not going to go through reading each one of them. We're going to dive right in. Next slide. Briefly, Medicaid is a cooperative joint venture. It is funded by both the federal and state governments, and that does include the District of Columbia and the territories. It's important to understand that Medicaid is not a cash support program. It actually pays for medical providers directly for care that is provided to beneficiaries. You'll also hear the word entitlement. It is considered a federal, state, and entitlement program, and it did begin initially as a program focused in on helping to pay for medical assistance for families with limited income and resources. And you'll note that I've put a brief definition of what entitlement means. It does mean that if you as a state have a Medicaid program, that at a minimum you must have within your program the eligibility categories that the federal statutes guarantee certain benefits to specific groups, and you're going to hear about them shortly. I will note that over the years and prior to the Affordable Care Act, Medicaid has become not only the largest source of funding for those with limited income and resources, but it's also now the largest source of funding for medical and health-related services for seniors and individuals with disabilities. Next slide, please. As I noted about Medicaid administration, I want to talk for a couple minutes on two things on this slide. One is that there are federally established national guidelines. So even though it is a federal-state partnership, you do still need to follow the federal guidelines. And states do receive matching federal funds, and that can be very, very confusing for folks. There are two types of matching funds. What I have on here is the funds that are known as FMAP, or Federal Medical Assistance Percentage. And that is the matching funds that are used to pay for the actual health services. That match rate varies from state to state, and there is a calculation for it. And certain eligibility groups and administrative costs receive a higher match. We also have what is called FFP, Federal Participation Rate. FFP is paid for on the administrative costs. So you've got FFP to pay for your administrative costs, and then you have FMAP to pay for the actual medical services. And as noted, certain eligibility groups, for example, the CHIP program is matched at 65-35%. So when you hear that, what does that mean? It means for every 65 cents that the Fed put forward, or CMS, our federal partners, pay for on a dollar of health care, the state has to match it with 35 cents. Most administrative costs are, in most states, are at a 50-50 split for regular Medicaid, meaning for every 50 cents of the dollar, there's 50 cents of state funds. There is a chart if you're interested in knowing about what your state has for match, if you'd like to see it. Let's go to the next slide, please. When I was mentioning within federal guidelines that a state has to administer their program, each state has what they call a state plan. And your colleagues in Medicaid, you might have heard them talk about the state plan or a state plan amendment, also known as a SPA. And no, it's not one with a jacuzzi. It is a state plan amendment, and that's what a state has to submit to CMS in order to make changes in their Medicaid programs. So as you can see, there is some latitude to outline the nature and scope of services, but that state plan document, which is thousands of pages long, really is the contract between the Centers for Medicare and Medicaid Services and the state. If the state follows these rules, the federal government will provide the matching funds. And if you can remember that, particularly when you're brainstorming how to align your policies and procedures, it's always very important as public health programs that you have a member of your Medicaid team there that does understand the eligibility and administrative requirements, so that you don't start down the road of doing a lot of work to make a plan change to only find out that, in fact, you're not able to move forward. Next slide, please. There's also numerous payment methodologies. I'm sure you've all heard of these. Fee-for-service, which is pretty much out of the realm of most Medicaid programs, although I think most states always have at least a small component of their portion of their claims being paid under a fee-for-service model. And then, of course, managed care. And just to make Medicaid a little bit more complicated, we have a number of states that have been experimenting with, and some very successful with using different methodologies under the heading of value-based purchasing. So again, as public health HIV and Ryan White programs, you may hear your colleagues talking about, well, we want to do a bundled payment for that particular group of services. That's them trying to get to the place of value-based purchasing where the investment of the funds going forward produce positive outcomes, both in terms of the quality of care, but also health outcomes in overall. It's also important to understand that states do have to operate and maintain an adequate provider network, access to benefits, and so there's geographic and time requirements. And so, for example, in New Hampshire, if you go north of the middle of the state, which is the Lakes region, the number of pediatric orthodontist basically doesn't exist. Well, that's a problem. So a state is bound to make sure that in that instance, New Hampshire was required to make sure that children could get to a pediatric dentist if that's what was needed within a certain amount of time. There's also a need to run a claims payment system. So you might hear your colleagues talk about their MMIS. That stands for the Medicaid Management Information System. And all the claims that are submitted, even through a managed care organization, ultimately have to go through this system that is certified by the federal government and monitored for correct payments and have to be done within a specific time frame. And then finally, they also have to maintain adequate provider reimbursement rates, which I'm sure you've all had conversations at one point or another about. In your travels with your colleagues and maybe with legislators, you'll hear things such as, oh, you know, Medicaid supplemental payments, or DSH, capital DSH, an acronym for disproportionate share hospital payments, and cost allocation. This is really too much for us to go in today, but it is representative of how incredibly complex the Medicaid program is. And there really is nothing such as a simple program change or a simple SPA or a simple waiver. So try not to get trapped in that mode if you hear anyone talking about anything being simple. Next slide, please. There's also this concept of the single Medicaid state agency, and it's strictly a statutory or legal concept that defines the responsibility for administration of the Medicaid state plan. The single state agency isn't required to administer the entire Medicaid program. It may delegate some administrative functions to other state or local agencies or private contractors, but in the end, all final eligibility determinations must be made by state or local agency personnel. So within every state, it's how Medicaid fits within the state bureaucracy is different. In New Hampshire, it was all part of the umbrella Department of Health and Human Services. For some states, it's within a Department of Human Services, Office of Public Assistance, the Department of Social Services. Sometimes you have to look around a little bit if you're trying to see what's going on in another state to find exactly where your Medicaid administration is. But just be aware that when you've seen one Medicaid program, you've seen one Medicaid program. So let's go to the next slide and talk about Medicaid eligibility. I swear that someday there's going to be a university that puts out a PhD in Medicaid eligibility because it is extremely complex. To qualify for Medicaid, you must belong to one of the eligibility groups that is specified under federal Medicaid law, and that your state has chosen to cover within your state if it's not a mandatory group. So let's talk about what the mandatory groups are. For example, pregnant women and children are a mandatory coverage group. A state cannot have a Medicaid program without covering low-income pregnant women and children. We also have a thing called Medicaid, maintenance of effort, which we'll talk about in a minute. So there are some states who say they're the minimum income level for pregnant women is 133%. You might hear the term federal poverty level. Federal poverty level defines the income level at which an individual, that number, that percentage is eligible for the Medicaid program. The federal government said you have to cover pregnant women up to 133% of the federal poverty level. Every year around February, the income levels that calculate out to those federal poverty levels are updated, posted in the Federal Register. You can Google them very quickly if you want to see what a household of one at 100% of the federal poverty level, or a family of 4 at 170% of the federal poverty level, what that income level is. And some states, even though there is that minimum threshold, for example, for pregnant women of 133%, for example, in New Hampshire, many, many years ago, we decided to increase that to 185% of the federal poverty level. Now, why is that important to know? That's important to know because as changes are made in the federal law, if there's a requirement for maintenance of effort, generally what that means is, as it did for example New Hampshire, when the Children's Health Insurance Program came along, one of the questions that was asked of me was, well, is there any reason why we can't lower the income level for pregnant women from 185 back down to the 133? Well, yes, there is, because there's a requirement that the state maintain its current level of effort, usually to a date certain. And I mention that again only because it's terminology you may hear as you work with your Medicaid colleagues and as you make your travels throughout the state. The last thing I want to mention about the eligibility piece right now is that, as if it's going to be complicated enough, you have financial eligibility, but for some of these eligibility groups, for example, people with disabilities or seniors needing long-term care that's going to be funded by Medicaid, you also have to go through non-financial requirements, such as medical eligibility determination. There's all kinds of federal rules around estate recoveries and third-party insurance coverage. As I said, this would be a heck of a PhD for a university to put out there because it is so complicated. Of course, now because of the Affordable Care Act, states have had the option to cover additional groups, and we'll talk about those in just a few minutes. Next slide, please. Briefly, who can determine Medicaid eligibility? As I mentioned before, the state ultimately is responsible for determinations, even if they decide to partner with their insurance marketplace, if they decide they want to outstation eligibility workers, say, in a hospital, or if they want to have implement an eligibility initiative called presumptive eligibility, which I'm not going to go into right now. We'll talk about that as a separate topic at another time. But my point in bringing this up is the state's ultimately responsible, and there are audits, routine audits, and sanctions that can be applied to the state based not only the timeliness of determinations, but also the percentage of correct determinations. Now, this is important to public health programs because you, in fact, may have a role in determining Medicaid eligibility. Yes, there are federal requirements about how fast a state has to determine Medicaid eligibility. But you all know, and very similar with other public health programs such as substance use disorder programs, mental health programs, which I don't, you're all connected in many ways. You have somebody who walks through the door who is in need of health care, and the time is ripe to actually get them involved in health care, particularly around the diagnosis related to HIV. You want to be able to provide those services, find out if they're eligible for Medicaid, and then build a Medicaid program. And so one of the options that I would encourage all of you to talk with your Medicaid programs about, and this was something that I leveraged in New Hampshire as much as possible, is presumptive eligibility, where you as a public health site with the appropriate training can actually screen for Medicaid eligibility, help an individual go through an eligibility process, which has become much simpler, as you'll hear in a few minutes, and be able to, if in fact you determine them presumptively eligible, be reimbursed for the services during that presumptive eligibility period. And if this is something that any of our participating states want to have some one-on-one conversation about, I'm very happy to do that, but I would encourage you first to talk to your Medicaid colleagues. Let's go to the next slide. I'm not going to go into this in detail in case you are a state that works very closely, or your Medicaid program works closely with the marketplace. I wanted you just to see that there are two different ways to work with the marketplace, and you may hear them talking about this. And I wanted you just to have this as a slide to be able to refer to in case you hear it come up. Next slide, please. Let's take a minute and talk about the application and enrollment process. Nowadays, it relies primarily on electronic data for the application process. And that was designed by our federal partners to try to do their best, and all of our best, to reduce the need for paper documentation. I'm sure you've heard stories of, oh my God, I had to find a birth certificate. I couldn't find the birth certificate. I had to have, 3 pay stubs. I had to have this, that. Well, one of the goals was to really reduce all of that, because obviously if you are eligible for Medicaid, it can determine your time to access to health care. And so it's important that this became a policy effort within the prior administration. And the electronic data has saved a lot of headaches for a lot of people. There is, most states have a 12-month eligibility period, meaning that once a year, adults, parents, and children have to be redetermined eligible. Some states have a shorter amount than that, but most are 12 months. And many states have now gone to electronic application process. And if anyone wants, if your state doesn't have electronic, which I think most states do now, but if you'd like some examples of state eligibility systems that do in fact have the electronic connection, it's a web-based portal, just feel free to let me know. Next slide, please. One of the other aspects of the Affordable Care Act was a requirement that there be a streamlined application so that there weren't multiple applications for Medicaid and the Children's Health Insurance Program. There was all kinds of work done on trying to standardize different pieces of the eligibility process. States have to accept applications by either online, by phone, by mail, or in person. Some folks are enrolled immediately once eligibility determination is complete. And depending on the program for which the applicant is eligible, if it's just a financial eligibility criteria, obviously that's going to be quicker than a medical eligibility determination, which requires provider documentation to come in and a clinical review of actual records. And of course, there's healthcare.gov, where anyone who's interested in Medicaid or CHIP can go to that website and apply. Let's go to the next slide, please. Here's another part of the PhD program. As part of the Affordable Care Act, there was a complete change in how gross income, or how income was counted. And again, I'm only mentioning this in case you hear your colleagues talking about it. And it's modified adjusted gross income, or MAGI. And it was a new way to count the income towards Medicaid eligibility, how to look at household composition, and how family size is determined. And it's not something that you just look on your IRS tax form to find. There are specific rules, and those rules are spelled out by your state, and it's based on those rules and an algorithm that's built that financial eligibility is determined. Next slide, please. In terms of the MAGI-based income methodology, you do have to look at individuals' taxable income. This is what your state colleagues who work out in the eligibility field have to learn these rules inside and out. There used to be a bunch of different what they called income disregards, and you may hear that too. If you're working with a client who says, you know, I used to have an income disregard of X percent, it was all over the place. So finally there's just one, which means that if you go in to apply for Medicaid, right off the top, the eligibility worker is going to take 5% of your income off. It's just part of the federal rules. And you can see that there's other issues around household composition, and because child support and some other assistance is not considered taxable income, then it's not tied into to the individual's financial eligibility determination. Next slide, please. So that was probably more than you would ever want to know about financial eligibility. My takeaway message there is there's a lot of acronyms thrown around. It seems really complicated for folks, particularly if they're being challenged by either health issues or other psychosocial issues. And so developing relationships with your Medicaid state agency, with the workers that are out in the field, the ones who are answering individuals' questions through, say, a client services unit, it is a really good idea to develop and nurture those interpersonal relationships, because they are your best source of information if you have a question or one of your sites has a question about Medicaid eligibility. The last thing I want to mention about this is about the non-financial or medical eligibility. I did note for you that there are other additional medical clearances that some populations have to go through, and I'm not going to touch upon each one of these programs. It's just to say, again, here's some terminology that you may hear folks talk about in terms of a particular type of Medicaid eligibility program, and to give you a sense of, oh yeah, that's one of those that isn't just an easy income. There's also some medical eligibility criteria to be met, particularly for disabled adults and children and individuals seeking nursing home care. Okay, next slide, please. So one of the biggest issues, of course, is verification of income and residency. I'm not going to go through each one of these. I want to point out a couple things, though. There is, if you look at the two bottom bullets, there's definitely a decreased reliance on documentation and an increased reliance on self-attestation. Again, terminology you may hear, where, yes, somebody is at some point going to have to show that either they are a U.S. citizen or a legally in the country, but there are special emergency circumstances when somebody who is not either hasn't completed a U.S. citizenship process or hasn't gone through the process to have the documentation that says they are legally in the country. There are specific emergency situations where the Medicaid program can choose to cover costs, and the one that stands out the most is for women who are pregnant, who suddenly, and this happens a lot, shows up in the emergency room. She is, and actually is far along in her pregnancy and is ready to deliver. This was a protection put in place so that we didn't see women turned away who are not, don't have their paperwork, but who are getting ready to deliver a baby. Again, more than you probably needed to know, but I want to make sure that at least you get a taste for, okay, now we have this other complication of the Medicaid program, and another reason to have a great relationship with your eligibility staff. Next slide, please. I'm going to, again, you can refer to this documentation proof I'm not going to go into today. It's just that I wanted you to be able to have the background information. Next slide, please, Kiara. Let me talk for a few minutes, and I am watching the time here, on the Medicaid eligibility expansion. And I know not every state did an eligibility expansion, but I want to make sure that if your state did do an expansion, that you at least are familiar with some of the provisions of what that expansion meant. And it did mean three primary new eligibility groups. And they were folks who prior were not eligible for Medicaid. For example, an adult group of folks 19 to 64 years of age who meet a certain federal poverty level. Other than being disabled prior to January 1st of 2014, there was no way for them to easily become Medicaid eligible. There's also some special provisions under the Medicaid expansion and the Affordable Care Act. And from a state agency perspective, you might want to be aware that if you have a client in your program or who comes to one of your sites, your healthcare sites, that's under the age of 26, and they were once in the foster care program within your state, they can actually be covered under Medicaid until they turn 26. Before, everyone, once they hit 18, they'd age out and were left holding the bag. So that's important to know in terms of the folks that you're working with. The next slide shows you just a quick map. Grateful to the Kaiser Foundation who did a recent map on where expansion has and hasn't been across the country. Again, just a reference document. And the next slide that says insurance coverage without expansion. This is taking what I had said previously about complicated Medicaid and now affordable care, Medicaid expansion, complexity, and tries to make it into a picture, a graphic that will help to explain it. I'm not sure whether it did or it didn't, but what it really says, if you look at the bottom right-hand side where it says Medicaid and CHIP children, you had decent coverage. But if you come to the left where you see the boxes with the stripes, and then the box up above that says marketplace subsidies, if it was prior to January 1 of 14, that would all be blank. So again, just another way of looking at the information. In terms of the next slide, states not expanding coverage under Medicaid, I'm sure you all are familiar with, I'm sure you've heard the discussions in your state. So I'm not going to dwell on this, but I do think it's important that you consider ways that Medicaid, perhaps from an eligibility perspective, setting aside an expansion, again going back to this idea of presumptive eligibility, can actually be leveraged in your state so that individuals who come to your health centers, your HIV, Ryan White, public health sites, have the opportunity to be screened and deemed presumptively eligible for Medicaid if in fact they are, so that you reduce the time to accessing treatment. Okay, let's talk about Medicaid benefits. That's the next slide, please. So there's a set of mandatory Medicaid benefits. They're listed out here. Some of these are going to seem very familiar to you, and others may not. And if there's a specific benefit that you want to hear about, just type in a question to the chat box, and I will go back to it. The next slide continues the list and calls out some of the other Medicaid mandatory benefits that every state Medicaid agency has to provide. So let's go to the next slide and just talk for a minute about what is the difference between a service, a mandatory benefit that's covered under a state plan versus LTC, which stands for long-term care, and that's primarily refers to nursing home care or nursing home level of care that is provided in a home and community-based care setting. And then the other acronym is LTSS, long-term services and supports. And those are individuals who, for the most part, the goal is to have those folks live in a community-based setting, whether it's their actual home or with a caregiver, etc., to avoid institutional settings. These can be adults, they can be children with disabilities that, without these home and community-based care services, would not do well living at home. You need those extra services. Now, why am I telling you about these folks? I'm telling you about them because one of the myths of Medicaid is that you'll hear folks say, oh, we have a waiting list for our long-term services and supports waiver. Well, the piece of the puzzle that's missing there is, yes, they may be waiting for a place to receive these home and community-based care services within the home, but they are eligible and can receive all of the mandatory medical benefits that are covered underneath the state plan. And often, folks don't understand that. Again, just a point of interest in case in your conversations in the hallways you hear about long-term care or long-term services and supports. And how do they relate to the state plan? They are connected. Next slide, please. Just like with other with commercial insurers, there are opportunities for states to do benefits management. You'll hear the terms utilization management. So, for example, a state with approval from the federal government can put limits on the amount and scope of a particular service. So, for example, they may say you have 20 physical therapy visits per year. They can have a requirement for prior authorizations. They can have, your state can put in requirements for what they call pharmacy step therapy. Now this would be germane to the public health programs because with the, let's take cardiac drugs, for example. Not that that has specific for your clients, but just as a good example of step therapy. There might be 5 drugs that treat the same condition within a cardiac diagnosis, and some states will have a pharmacy policy where you have to start with the least expensive and work your way, fail going up the list until you hit the top medication. As with any rule, there's always exceptions. And there's always, 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 no matter if you're talking about eligibility or benefits, an appeal process that a beneficiary can exercise. And in fact, it is the state's responsibility to support that appeal process. Finally, there can be pharmacy preferred drug lists and formularies. It might be helpful for all of you who haven't done this. Ask your Medicaid state agency which of the HIV/AIDS-related pharmaceuticals are on your preferred drug list or in your formulary. Which ones do you require prior authorization for? That's good information to have. And if you have Medicaid managed care in your state, ask the same question about the managed care organizations, so that you have that information. Okay, next slide, please. That big Medicaid concept to talk about is waivers. Everybody thinks that you can absolutely waive everything under the federal Medicaid or CHIP, Children's Health Insurance Program statute, and that is not true. CMS does have the authority to waive some of the requirements, but not all of the requirements. And there are different types of waivers. Of course, there's not one size fits all, and when you've seen one, you've only seen one. So when you say you're going to waive our federal requirements, so what's a good example? Well, one might be statewide-ness. If you don't have a Medicaid waiver in place to speak to statewide-ness, it means that whatever you are offering in one part of the state for a Medicaid, for example, benefit or somebody who's eligible has to be available to everyone across the state, unless you have permission from the Centers for Medicare and Medicaid Services to limit a particular eligibility category or type of benefit to a specific part of the state. So what are some of the things you might hear? You might hear, oh, we've got a 1915B managed care waiver. Well, what does that mean? It means that your state has received approval to run a Medicaid managed care program. But even within a waiver, there are still requirements. So don't let anyone think that it's a free pass to do whatever the heck you want under managed care. That's not the case. There's also this waiver called a 1915C. You'll hear a lot about those because states are undergoing a lot of changes with those. And that's where you get those home and community-based care services. Things that normally the state plan would not pay for that can be provided in a home care setting to eligible individuals so that they can remain in the home. And then the granddaddy of them all, or maybe I should have said the grandmother of them all, is what you call your Section 1115 waivers. You'll hear people talk about 1115s a lot. They are 5-year demonstration waivers that are based upon a hypothesis, and again, with federal approval, it allows you to test out different healthcare delivery systems, different types of benefits, perhaps different financing mechanisms. And if your state has one, it's good to know, what is that 1115 doing for our state? Some states, back when I first became a Medicaid director, they wanted to do special services for individuals diagnosed and living with HIV, and the states had to go through an 1115 waiver. And I remember thinking, oh my God, we're never going to get through this. It's a lot of work to put it together. And I'm happy to say that over the past 10 or 15 years, our federal partners have done a really great job at making the process itself to apply for an 1115 easily understood and much more user-friendly. And so, again, you might want to ask your Medicaid colleagues, do we have any of these waivers? And what do they mean? What exactly are we delivering, and where are we delivering it? All right. Just keeping track of time here. I want to just spend a couple minutes on the Affordable Care Act. This is not a commercial for it. I want you to understand what that means, because I know many of my colleagues that I actually worked with in Health and Human Services, if you don't work in Medicaid every day, you may not understand, well, why is everybody having concerns about the ACA, and ACA gets confused with other terminology. So what my purpose in sharing this slide is that to say it did create some new opportunities that focused in on individuals that ultimately could benefit in terms of receiving health care services. So for example, you might be aware that there is a provision within the ACA that allows for the creation of what they call health homes. And these are for individuals with chronic conditions. And some states have actually created health homes around, for example, substance use. Some have, there's been at least one, probably more now, that created health homes specifically focused on individuals living with HIV. So again, ask your Medicaid program, do we have these? And if you do, get to know them, get involved. it'll just help build your toolbox as a public health program. Okay, next. If you thought a PhD in Medicaid would be a good idea, I don't even know what to call a degree if you got it in both Medicare and Medicaid. You know, two programs that do an incredible, wonderful, bring incredible, wonderful things to individuals' lives that are within the same umbrella organization of the Centers for Medicare and Medicaid Services, but sometimes because of different federal regulations have a hard time integrating. So the next slide that I have put in here says the differences between Medicare and Medicaid. Again, I'm not going to go through each one of these, but you know, the big takeaway here is Medicare has its own set of federal regulations, and it targets individuals who are over 65. And then there are some diagnoses such as end-stage renal disease, where if you're on dialysis, you can, no matter what your age, you can become eligible for Medicare. You will hear, though, possibly in your travels, next slide please, this population of Medicaid, Medicare eligibles, and people will say, oh, the duals, or the dual eligibles. And actually there's over 10 million people who are both eligible for Medicare and Medicaid. And within being eligible for Medicare, there's even breakdowns with that or breakouts in terms of Medicare. You know, you could have someone who is eligible for the full Medicare and Medicaid program, but on the Medicare side, you can also have folks that may only be eligible to have part of their Medicare premium paid. Again, we're not going to get quizzed on this. I don't expect you to know this at the end. What I want you to be familiar with is that there are individuals in your state that are eligible for both programs, that coordination of benefits between the two programs is a really great goal, and that they're called either dually eligible or short duals, D-U-A-L-S. The next slide actually puts the eligibility criteria there. For those of you who just can't get enough of this and you really want to get into understanding the different Medicare eligibility groups and what Medicare helps to pay for, or if you're like me who has an older parent that I really appreciated the first Medicare webinar I went to, because I could then understand what the heck is Part A and what's Part B, and it helped me, and more of us are finding that we need to have that information. But in your professional life, if you're interested in this particular topic, there's a slide for you. We're almost done here, folks. The Children's Health Insurance Program, that's been around since like the late 90s, 1998, 99. It's also known as the Title 21 program because it falls under, the regulations can be found in Title 21 of the Social Security Act. Let's go to the slide, Kiara, past CHIP overview to what is CHIP. Same as Medicaid in many aspects, except that it targets children specifically, and children at higher income levels. And every state, of course, is different, and the state does receive federal funds. Next slide, please. And there are options around your CHIP program. It can be part of your Medicaid program, or it could be a standalone program. Of course, again, as I said, this is a complex program, and it can even be a combination of two programs. So what's different about CHIP? Let's go to CHIP eligibility. Well, first of all, you have to be under the age of 19. You have to be, income limits tend to be higher. For example, in New Hampshire, we go up to 300% of the federal poverty level. So 24 states do cover children at 250% of the federal poverty level or higher. Now, why is this important for you to know? Yes, you have to be under 19, But we also know that adolescents are not immune to dealing with issues, whether we're talking sexually transmitted diseases such as hepatitis C or other STDs or HIV. And, insurance coverage at one point, particularly back in the late 90s, was so darn expensive that parents would often be able to get an employer-sponsored insurance. There hasn't been a high degree of employer-sponsored insurance across the country. And so you start looking at those premiums, you're like, oh, my kids are really, they might be really healthy, and so I'm going to, I may not have insurance for my child through my employer. And this helped parents start to cover their children. And there are specifics around eligibility limitations because, of course, if you go to the next slide, some states had some really interesting ideas. For example, I, as a state employee, I remember being asked, well, now that we have this children's health insurance program, why can't we take all our state employees who have children, take their children and put them on the CHIP program? Well, there's a federal law against that. So that is a limitation that often isn't well understood out in the world that we all walk in. Inmates of public institutions, so again, question might come up, well, we have a youth center. Why can't those kids be covered under the CHIP program where we can get some federal match as opposed to using 100% general funds? Well, you can't. That is the federal law. You cannot do that. And the biggest difference that I would point out between CHIP and Medicaid for kids is under CHIP, the child has got to be uninsured, whereas on Medicaid, a child can have Medicaid but also have a third-party insurance. So again, probably more than you ever wanted to know, but at least you've been exposed to the concept. And on our next slide, again, we have a maintenance of effort. CHIP authorization for funding, it's totally separate from Medicaid, and we have recently had an extension of that funding. It was reauthorized. That's good news. And our last slide. So why is all of this important to public health, HIV, and Ryan White programs? Well, again, integrating both Medicaid and public health programs, one of the things there is the art and the science of public health, which as a graduate of a public health program I get, and I've always tried to apply it to the Medicaid population because there are really good things to bring there. It's important to understand what are both of your, what's your purpose and what's your limitations. You can look at integration from perhaps an alignment of policy. Maybe you can work together on your providers and your provider network. What can you do from a client services perspective? How about a pharmacy benefit management? In New Hampshire, the public health HIV program was struggling like crazy with their pharmacy benefit management. And one day I said to Neil Twitchell, well, why don't we do a joint contract and have one vendor and work together on this? And that was one of the best changes that we ever made. Also, again, getting back to this idea of presumptive eligibility, geez, maybe if that's something that your state wants to do, you'll improve timely access to care through leveraging eligibility screening opportunities. Maybe there's a good opportunity to do care coordination, particularly with your states that have a managed care plan. You know, let's avoid duplication of efforts and confusion for the person that's on the receiving end of our services. Another great place to integrate is let's align quality improvement initiatives. And this gets to one of our big learning communities, sharing of data and data analytic capacity. The quality improvement initiative alignment is really important because now Medicaid has mandatory quality measures. We know that there's limited resources within a state. So, and you know that providers, one of their biggest cries is, don't have me work on a dozen different quality measures for my, I've got Medicaid, I've got the Anthem, I've got the Cignas, I've got all these commercial insurers, and now I have Medicare. So let's do what we can to align those quality measures. Ultimately, that is going to improve the overall health of our beneficiaries. Let's see. The other last thing I will mention, or two last things. One is that you really want to collaborate on leveraging available CMS authorities by looking at, again, this is the idea of, geez, could we do a health home? I don't know. Well, how about if you work together and get the subject matter expertise of your both federal and state Medicaid folks and your clinical staff? Let's work together and not alone. And this is the last thing I'll mention. There was a recent Health Affairs article, which we've put the link here, that showed the impacts of the Medicaid expansion under the Affordable Care Act on people living with HIV. And we thought if you hadn't seen it, or I thought if you hadn't seen it, and our partners thought if you hadn't seen it, you might just want to take a look at it. All right, that was a boatload of information in a very short time. You have my email address there. If there are questions that you have that you don't want to ask via the webinar, if you want to do some follow-up, you are more than welcome to email me. And lastly, I'll say thank you for your attention. I know this was an hour of jam-packed information, and I really appreciate the opportunity to work with all of you. I'm going to turn this back over to Michelle.
Thank you. Thank you so much, Ms. Dunn, for that very informative presentation. I learned so much more just from listening to you today. Now at this time, if any of the states have any questions for Ms. Dunn, please write your question in the chat box. Thank you again. Hi, everyone. At this time, we have no additional questions from our participants. Therefore, I'm going to use this time to, once again, thank Ms. Dunn so much for her awesome presentation, and thank you, our learning communities, for coming to our webinar today. I will take this time to give you a few reminders that you have received in the past, but just as a reassurance, tell it to you again. Now, my first reminder is about funding opportunity. As you know, the Health Resources and Service Administration released a funding opportunity, HRSA-17-045. All of the information was provided to you from the National Academy of State Health in their recent January 24th monthly digest. So I wouldn't belabor you the point in telling you all about it. You have the link and the information that was provided to you. The second announcement is regarding an upcoming webinar to be held sometime in March. It's on data privacy and confidentiality. The National Association of State Health Policy will provide you additional information about this webinar sometime before the ending of this month. And lastly, we want to put an edge there for you about technical assistance opportunities. Please remember that each state is welcome to submit any individual technical assistance opportunities. Please do not submit the request to your learning community leads. We would like you to submit all of your requests to HIV technical assistant-NASP.org. And they will follow up with you about making sure that your request is linked to the appropriate people. Now, we love to hear from you about how this webinar went. You will have a webinar evaluation. Please remember to complete the evaluation that will open in a new window after we close out the webinar. I will now let the folks from the National Association of State Health Policy provide you any additional information on next steps. Once again, thank you so much for joining us today.
Thank you, everyone. As soon as you close your window, you should see your evaluation. And thanks again for joining us today. Have a wonderful rest of your afternoon.